Good morning. Today is August 12th. We have two budget hearings this morning. The first is Northwestern Medical Center. I'll have Mark Henksler, our counsel, swear in the witnesses, and then Mr. Wright, I'll turn it over to you and your team for your presentation, followed by board questions.
Hey, good morning to the folks from NMC. I will administer the oath. What I'm going to ask you to do is after I administer the oath, unmute yourselves, and then individually, if you can state your name and then affirm the oath. That way we have each person testifying for NMC on the record. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
My name is Peter Wright. I'm the president and CEO of Northwestern Medical Center. I do. I'll introduce, or I swear. I'll introduce Barbara Toof, the chair of our board.
Hi, my name is Barbara Toof. As Peter said, I am chair of the board, and I also affirm the oath.
Stephanie Bro.
Good morning, Stephanie Bro, CFO at Northwestern Medical Center. I also affirm the oath.
I'm John Minadeo. Good morning, Chief Medical Officer and Chief Quality Officer. I also affirm the oath.
Okay, witnesses are sworn in. I'll turn it over to NMC for its presentation.
Thank you, sir. Chair Foster, members of the board, I want to start by saying thank you for your service to the great state of Vermont. It's never lost on me the daunting task that you have in front of you, and we appreciate the opportunity to talk to you a little bit about the journey that we're traveling on and the budget that we've submitted and where we see Northwestern Medical Center moving forward and how we plan on taking care of the people of Franklin and Grand Isle County as we've done for the last 142 years. So we appreciate that. I'll take the opportunity just to introduce my team again. Barbara Toof is the chair of our board. She is worked for People's Trust Bank and has been a part of our community for a very long time and does a really good job leading our board in a very thoughtful way, always putting the people of our community at the forefront of their work. You're familiar with me. Stephanie Bro is our Chief Financial Officer. Stephanie's been with our organization almost 20 years and has served in the role of Chief Financial Officer for, I think it's the last 5, Steph?
Close to that.
Yeah. And Dr. John Minadeo is our Chief Medical and Quality Officer. Dr. Minadeo has been with us for 26 years, came to us right out of residency as an emergency room physician, and has served in that role for a great part of his career. Has worked on several quality projects, became the department medical director, and about 5 years ago became our Chief Medical and Quality Officer. So those are the folks who are going to chat with you today. Go ahead, Steph. Stephanie's going to control our slide deck. So this is our summary of our strategic plan. We operate on 3 basic but strong pillars. Quality and safety always comes first in everything that we do. It's the first thing we talk about at all of our board meetings. It's the first thing that we talk about at our senior leadership meetings. And the first thing on the agendas at each of our meetings. We aspire to be a Leapfrog Grade A and a CMS 5-star hospital, and you're going to hear Dr. Minadeo talk again, as he has in years past, about our journey to become a high reliable organization. Our next pillar is engagement. Obviously, that's really important, not only engagement of the patient, but engagement of our team, of our board, our medical staff, our leaders, our staff, and our community. So we work really hard. You're going to hear the word transparency a lot. We are very open book about our quality and safety data, about our patient satisfaction data, and about our financial and stewardship data, as well as the plan. Some of the slides that you're going to see today are about how we're sharing healthcare transformation, how we're sharing the good and bad and the ugly of where we are and where we're moving towards with the organization. And we think that that level of engagement is really important to not only move our organization forward, but move our community with us. And of course, we are entrusted to be good stewards of the community resources. We often say that we don't have stockholders in our organization as a nonprofit, but we have stakeholders, and our stakeholders are the members of our team and the community that we serve. Go ahead, Steph. I'm fairly sure we paid our internet service provider bill, but maybe the check didn't clear just yet. So, all right. So, you know, when we talk about affordability, like, we get it. We understand the daunting challenge that's ahead of you, that's ahead of us. And this is an area where we have been leaders in the state. Every time healthcare transformation has come about in the state of Vermont, Northwestern Medical Center has been on the leading edge. And we will continue to do that. We've already engaged with the Agency of Human Services about the transformation plans and discussions for Franklin and Grand Isle County. We're talking with our partner hospitals that are adjacent to us and our strategic partners in the community, mental health providers and primary care providers about what that will mean and how we can continue to lead in that way. As I said before, we're very transparent with our information. So we talk with our board of directors, our medical staff, just about what this means and how we need to lean in and drive the conversation, how it is that we can seize the moment to continue to control our fate and our destiny, and how we can continue to provide healthcare for our community for another 142 years. We've been working on this not just the last couple of months, but for years. You all are familiar with the New England Health Collaborative. That started over 3 years ago with conversations about how we can come together with peer and like hospitals, both in Vermont, but outside of our state, to figure out how to be more efficient, to figure out how to reduce cost. Some of that is how do we reduce clinical costs, but a lot of those conversations are about how do we reduce non-clinical costs in the background. So one of the conversations that we're having right now has to do with IT. We all have IT data centers, and we all spend money on that. How can we come together to spend less money, to be more efficient, to provide a safer environment for our information by working collectively with our now 10 partners and soon to be more in the coming year in the collaborative. We work with the state of Vermont. You know, we work with you, the Green Mountain Care Board, and the Agency of Human Services to figure out what do you see as healthcare transformation. You know, we don't always see things the same way, but we also know that we're not always right. And so leaning in and bringing different opinions and different views is how we shape and grow and develop and continue to provide leadership. So we really appreciate the opportunity to work with you and with others to shape the future for healthcare in Vermont. We've worked with the Rural Healthcare Redesign Center and their evolving role. And we've taken the opportunity in the last year to work directly with Blue Cross Blue Shield, inviting them in and saying, we have some ideas about how healthcare costs can be reduced for our community. And so we've been working with them and pivoting our relationship of one that, you know, I wouldn't say was antagonistic, but in any kind of negotiation on rate, and flipping that upside down and saying, you know, what programs do you have that can drive down cost? Here's where we think that we can be a solution to driving down cost for our community. And I think we've done that. You know, last year we talked to you about healthcare costs that we were able to lower, not in our own budget, but with our community partners through the collaborative, you know, that plain and simple help commercial ratepayers spend and pay less for healthcare costs in Franklin and Grand Isle County. Go ahead, Steph. So I'm going to turn it over to Dr. Minadeo, who's going to talk to you about very important, our value equation and our quality journey. Dr. Minadeo.
Good morning. Thank you for the opportunity. So this is a slide that we shared with the entire organization at our last town hall, and we also shared it with each medical staff meeting. So our message was change is happening. healthcare is being redesigned, and we understand that change is needed, and we want to be part of it, not just a passenger. So we said we need to keep our focus on the quality of care for our patients, because if value equals quality over cost, and we've long been established as a low-cost provider, as we increase our quality, then we further increase our value to the system. About 4 years ago, we introduced universal education on high reliability principles and practices. And about 3 years ago, we added lean daily management, Gemba boards in each unit, and leadership rounding. And we're going to show you some data. And while data sets always go up and down, I think we should be proud of our progress that we've been making. So we can go to the next slide and just show you some of that data set. And this is a quality dashboard that we present to our leadership team every month, as well as the board of directors every month. The left-hand column, you'll see a list of safety metrics that I'm sure you're familiar with. They are the publicly reported metrics used by CMS in their star rating to compare hospitals, in Leapfrog, their safety grade. They are hospital-acquired infections, surgical site infections, hospital-acquired conditions, sepsis bundle compliance, hand hygiene, readmissions, patient experience, et cetera. So as I mentioned before, there's natural variability and runs in any data set. You can flip a coin, 3 times in a row and get heads. That doesn't mean you're talented. But having said that, you can see the red arrows are pointing to 4 separate metrics with year-over-year progress over a 3-year span. The top sort of highlighted box there in the blue row shows a total sort of a summation of the hospital-acquired conditions and hospital-acquired infections at our hospital in 2023. There were 28, 2024, 22, and then halfway through when this slide was made, 2025, we had 4. The next one is our sepsis bundle compliance at 51% in 2023, going up to 62 and then 66 in year to date in 25, with the national average being 63. You'll see some more current data in a subsequent slide. And then our hand hygiene, which also I'll talk about a little bit more detail in a minute, went from 84 to 88 to 91% year to date. And then the last box down there is sort of the patient experience, the overall patient, how did they rate our hospital overall, with the national average being at 72 percentile. We went from in 2023, 63, or 2024 to 68, and then year to date in the first quarter in 25 at the 75th percentile. And the next slide just shows some sort of similar idea. This is just data directly from CMS, reporting over a 2-year period from 2022 to 2023. The top section shows our facility, which shows all zeros for the particular hospital-acquired condition metrics that they chose in this slide, and the bottom section is a national comparison. And so where all zeros is where we want to be. Our sort of high reliability stated goal is 0 preventable harm. And my last slide here shows some progress over time over 2 of our organization-wide process improvement goals. The top shows year-over-year results from our hand hygiene initiative. The bottom blue line, the dark blue line, is how we did in 2021. National average of hand hygiene, you'll read anywhere from below 50% to as high as 65% of opportunities that hospitals are compliant with. We started around that 65% in 2021. Then orange represents how we did in 2022, green in 2023, the light blue in 2024, and the purple is our year to date in 2025. And so you can see with persistence and constant attention to it, we've improved that data year over year. The lower graphic is our sepsis bundle compliance, once again represented in a little different manner with more current data. The light green line represents the national how people do across the country on sepsis bundle compliance, which is very challenging to meet all of the different elements. And so the national average is about 63%. We started in 2023 on the x-axis there at about 30%, and then the most recent data set from May shows us well above the national average. And while it does go up and down, as I said, we think we're going in the right direction. So our message at the end of town hall was, while it's easy and understandable to be discouraged by the complexities and challenges of the day-to-day, we can look back at our results over time and take comfort that we're on the right path. So trust in high reliability, trust in lean efficiencies, trust in systems thinking, and trust in each other. And thank you for your time. I'll hand it back over to our CFO, Stephanie Breaux.
All right. Thank you, Dr. Menadeo. And, I just also want to say thank you to the board members and to the healthcare advocate. I especially want to say thank you to Matt and his team. They have been really, really good to work with through this process. And so I really appreciate them. I know you do too, but I just had to take a second and say that. Okay, so this graph here represents NMC's operating margin for the past 10 years. You can see we've been on a roller coaster ride, not the funnest of roller coaster rides. There's a lot of red on this graph, and the red really represents, over the span of those 10 years, over $30 million of operating losses. So again, as Peter said earlier, we are being really transparent with all of our staff. This is a graph that we show to all staff at town halls. We show it to leaders. We show it to medical staff. We show it to our board of directors because we want everyone to be on the same page as us, understanding that this is not sustainable. We have to make changes. And while the graph is really red, we have been working hard to improve. So going from fiscal year 23, having a negative margin of almost 7%, to fiscal year 24, negative 2.5%, right? That's a lot of work. That's a lot of expense containment and cost reduction. That's a lot of productivity enhancements. Going from the negative 2.5% in 24 to about a negative 2% in the current fiscal year. It's where we're projecting to be. As you get closer to that break even, and dare I say closer to a positive operating margin, right, the more difficult it is to improve. You don't have that low hanging fruit anymore. And so it just becomes harder and harder for us to find ways to positively impact our operating margin, but we're trying and we're dedicated and we're committed to doing that. We're going to talk a lot in our presentation today about this budget submission for 26 and how we don't feel like we're done with our budget process for 26. And that's because you can see the submitted budget has a negative 5.75% operating margin. And so that would be a really big step backwards for us. That is not what we're going for. We don't feel like that is something we can do. And so, we're here today talking about the budget we've submitted, but we feel like we still have a lot of work to do. And I want to talk about, well, how do you go from negative 2% to negative almost 6%? What's driving that change? And so that's on the next slide. All right. Seems like there's a lag, so just give me a nod if you see it. Okay. So we started really by, started our budget season the same way we always do. What are, volumes looking like? What's our utilization? What are our revenues? What's our payer mix? We put all of those things together and say, what should we expect for next year? Do we expect where we're currently running? Do we know something? Maybe a doctor is coming, maybe a doctor is leaving, maybe we have specific efforts to expand hours of service. What is it that we know that could cause some of these things to go up or down? And really for us, when we put together the 26 budget, we always strive to not budget too aspirationally, right? Don't plan for something unless there's a really solid, tangible plan in place. You can't just hope and cross your fingers that it's going to come to fruition. So most of our volumes and most of our utilization was very flat to where we're currently running. So really that budget results in about a negative $3.5 million operating margin, which is what we've been running, right? 24, 25, those fiscal years, we've seen a negative operating margin somewhere of negative 3 million, negative 3.5 million. So that was kind of our starting point. It looked a lot like where we are right now. From there, we built in a reduction to net patient revenue for the estimated impact of H266. And I know Peter is going to talk more about H266 later, but that was one big additional thing we added into the budget. Then we had to add in some additional expense because our OBGYN anchor physician is going to be leaving. He's going to be moving out of state. And so we're going to work on recruitment. But in the meantime, in order to really preserve and maintain that service, we have to get locum physicians. And so the difference in cost between having an employed physician and having a locum physician for an entire year to maintain that service was an additional $1.1 million of expense. So we had to go ahead and put that in the budget. We're also going to talk about that number a little bit more later. Then we added in normal inflation on things like supplies, contract services, and service agreements and contracts on equipment, our utilities, our insurance, all of those ordinary business expenses. So inflation for us on those items was worth about 1.2 million. And then we kept $300,000 in this budget for market increases for certain positions. So we do, I think like most organizations, we do a process every single year where we look at market data, we look at salary surveys, and we see where are we behind, where are we the most behind, where do we need to do a market adjustment, where are we having difficulty recruiting and retaining employees. So we have $300,000 in the budget for that. So that was sort of our story. There's many, many small positives and negatives. This is by no means all of the changes in the budget, but these were the major pieces that caused us to go from about a negative 3.5 million to a negative 8 million. NMC's true financial challenge really is closer to about $10 million, if we're being totally honest. We did not include any across the board increases for our staff in this budget. They were in there, but we pulled them out. We're going to talk about that also later on in this presentation. And we have done a freeze on all travel and education for our staff. So those are cuts that we have put into this budget to get to the negative 8 million, but those are cuts that they're not a good idea and they're not sustainable. So again, we'll talk a little bit more about those. All right, moving on to the Green Mountain Care Board budget benchmarks and how NMC stacks up against those benchmarks. The first benchmark was a net patient service revenue growth of 3.5% or less. NMC meets that benchmark. NMC actually has a negative 2% change in net patient service revenue when you go budget year to budget year. And the driver of that negative 2% is the impact of H266. Otherwise, our net patient revenue was really flat from year to year. The commercial reimbursement rate growth benchmark of 3% or less, NMC meets that benchmark as well. Our submitted budget includes a 3% increase to hospital inpatient and hospital outpatient services and a 0% increase in professional fees. So the net yield of that rate increase is 2.6%. So we meet that benchmark. And then the operating expense growth benchmark of 3% or less, NMC's submitted budget is an increase of 3.8%, but NMC is asking for a hold harmless expense growth of 1.1 million for that increase in cost that we just talked about for OBGYN physicians. And so if that hold harmless is granted, then NMC does meet the 3% expense growth benchmark. All right. Some other major budget assumptions, we have assumed no changes in our corporate structure, no significant changes in any of our service lines. We're not planning on adding any service lines, closing any. No physician transfers are built into this budget. We have very small changes in things like utilization and market share, payer mix, case mix, our 340B program, or any of our grants or other operating revenue. No material changes in any of those items. I'm going to hand it back over to Peter now, who's going to talk about some of our budget risks.
Thank you, Stephanie. So as you see on the slide, there are three major risks. There are obviously a variety of minor risks that kind of come in and out every day. But at the time we put the budget together, we did not understand the scope and the impact that I'll be honest, I really have a hard time calling it the one big beautiful bill. If you will indulge me, I'll call it the big ugly. Would have on the state of Vermont and the 45,000 people whose insurance covers that risk. We didn't have a way to understand or quantify that, so we're continuing to work with our partners across the state to do that, but that's not included in this budget. You have probably heard that our nurses unionized this past winter, and so we are in the early stages of negotiating that contract. And so we haven't accounted for any adjustments that may bring. And then, of course, you heard earlier that the budget as it stands will cause us to trip our bond covenants. And so that is obviously a very big concern and a very big risk for us that we are currently working on planning to mitigate. Okay, Steph. So I want to talk about H266 or Act 58 for a minute. As you heard Stephanie said, in the budget, our first estimate for that was approximately $2 million reduction in net patient revenue. As we've continued to dig in and understand more how that will impact, we actually believe that will be reduced to about 1.2 or 1.4, somewhere in there. Reduction in net patient revenue annually. And since the law doesn't go into effect to January 1st, so that's 3/4 of the year. So if we scale that back, the direct impact on the FY26 budget will be somewhere between $900,000 and $1.05 million. Go ahead, Steph. The other thing that we are learning as we dig through this is that we're really struggling to figure out how we're actually going to implement this. Our electronic medical record is not capable of the logic and interventions necessary to automate that, which makes it will be a manual billing process every single time that we do that. And that will, of course, add administrative costs and administrative burden. But we are still working through how we're going to do that. We still have some time, but it is incredibly complicated and something that we're really worried about making sure that we stay in compliance. Okay, Steph. You heard Stephanie talk about our operating losses when you saw that graph and all that red ink. And you heard her also say that we're leaning in hard to and you heard Dr. Minadeo say, how do we become a lean organization? How do we become more efficient? And what we've promised ourselves and hold ourselves to a very high standard and promised our board is we're not just going to continue to lop on expense. And this is a slide that's produced by the Green Mountain Care Board and something that we're very proud of. So this represents expense growth between fiscal year 2020 and 2025, and you'll see us all the way on the left with the lowest expense growth. It's been approximately 21% over those six fiscal years, or approximately 3.5% per year. So we feel like we're handling the challenges and becoming a leaner organization and making sure that we're doing that responsibly and not at the cost of increasing healthcare. Go ahead, Steph. Where our costs have increased, what this slide shows, this is a NASHP slide that shows where are our costs increasing. And you'll see, over the course of time, the green, the yellow, the purple, the blue lines, they're flat or in some cases declining. Those are all the non-patient care expense areas. The red line is the patient care expense. So this is where we've been investing our funds, either adding more to direct patient labor to open up access, or to be perfectly honest with you, a lot of that has to do with rate. We pretty much exclusively compete with UVM Medical Center and for our medical staff and our clinical staff. And, you know, competing with an academic medical center, if you look at other organizations that live in the shadow across the country of academic medical centers, scenarios is very similar. We can certainly take advantage and try to leverage every time we can. You know, the idea that we're small, and smaller means a different type of organization working on. And so we do intentionally lag about 10 to 20% behind the medical center. But, you know, we've absolutely seen the rate of all our clinical positions grow, and that's just the market that we're in. Not paying those rates and not increasing wages, which we talked about earlier as our concern, only increases the use of locum tenens and travelers. And so in order to stay competitive, we've moved. We do it very thoughtfully, very carefully. We use a variety of wage surveys for Northern New England, Vermont, New Hampshire, and Maine, and then we look at our local market. So we're very careful to make sure that we're comparing to like organizations and not just in our own neighborhood, and how we compare across the region. And it's an ongoing science and art that we spend a lot of time investing in to make sure that we're competitive without overpaying. Okay, Steph. I want to talk to you about this year's budget. So we practice a discipline of going through line by line every single one of our departments and implemented over 200 different expense reductions that quantified to $3 million. $2 million of that can be quantified in the 5 bullet points that you see just below that. The most notable are the top two. The across the board increase, which we've said we're really worried about and don't feel is sustainable or something that we should actually do. But for the purpose of putting together a budget and having a conversation with our board, we felt that was the responsible thing to start, as well as travel and education. Obviously, our staff, our providers, they have certifications and credentials. Those need to be maintained. That comes through continuing education. That's required, and you can get away with that for 1 year, but you usually run on 2 or 3 year cycles, and so that is not a sustainable mechanism. We've reduced a handful of our administrative consulting contracts. We oftentimes bring in experts to look at how a department is operating. We try to use our own talent, but we have and work with organizations across the country who are experts in the field of, say, how is our urgent care running? And, you know, are we using the right kind of labor? Are we using the right amount of labor? Is our throughput? You heard Dr. Minadeo talk about lean daily management and high reliability. So we use those tools ourselves, but we also lean on other organizations to help us get a look at how the rest of the world are doing things. We've been doing that a lot in the last couple of years, and so we feel we can back off of that a little bit. So we've saved $150,000 there. We've reduced an external pathology service contract. We were very successful in recruiting a pathologist in the last year, and so our reliance on that external contract has dropped, and that resulted in $170,000 worth of savings. We believe that's sustainable. And we're going to reduce the amount of marketing that we're doing in relation to recruitment. Our recruitment efforts have been largely, with 1 or 2 exceptions, very, very successful. And so we have the providers that we need in almost every area. And so we don't need to market for new providers, which is resulting in a drop of $158,000 there. Again, we are asking for the home harmless on $1.81 million of increased expenses related to our OBGYN locums. And that's all about being able to maintain that service until we can permanently recruit. So I'm going to turn it back to Stephanie to talk about some cash and where we've been over the last 8 years and where we're forecasting the next 8. Steph?
All right, thank you, Peter. So this is another slide that we have shared with our whole house, our staff, our medical staff, our board of directors. In the past 8 years, NMC has used a third of its days cash on hand funding operating losses and capital needs. And that reduction took place during an 8 years where the market was very, very good to us. So it would have been more than a third of our days cash on hand if the market was performing in a different way. We actually went back to, about the 1950s and looked at market returns. And it's hard to find, an 8-year span of time like the last 8 years we just had where market returns have been better. There's a couple times, but not many, where they've been better. So what we have said to our staff is, again, around sustainability and stewardship and having to come up with a financially sustainable way to run our organization. We've said, look, assuming we make no changes and we lose another $28 million from operations over the next 8 years, what does that do to us? And it kind of depends, right? It depends on market performance. If the market is good and returns an average of a positive 5% per year, then we'll have about 145 days cash on hand at the end of that 8 years. That's an okay number. It's respectable. If the market returns an average of 0%, so it's not positive, but it's also not negative, then we would have about 92 days cash on hand at the end of the next 8-year period. That's not a place that I want to be as the hospital CFO. Anything under 100 days is not a number that we would pick. It's not comfortable. That would be another violation of our bond covenant agreements. So that is certainly not a number we want to see. And then if the average market return is negative 5% during that 8-year period of time, well, we're in a crisis, right? This is 39 days cash on hand. That is no investment in our facilities, in our capital equipment. We're trying to figure out how to pay payroll and how to pay our vendors. That is not a space any organization wants to be in. So we share this with you guys today, just like we share it with our staff, to let you know that we are forecasting these things and we are seeing this as part of the picture of how do we get back to sustainability. I'm going to turn it back over to Peter to close things out.
Thank you, Stephanie. So I hope what you heard from our presentation today is that Northwestern Medical Center is leaning into value. It's about affordable care, but it has to be high quality care. And I apologize that I'm the one making you do math and do fractions today. But as Dr. Minadeo pointed out, value comes from quality over cost. I think that we do a very good job. We are a leader in Vermont in terms of where our costs are. You've looked at our quality journey, and we continue to improve and grow and get closer to our goal of being a Leapfrog A and a 5-star hospital. Those changes need to be careful and sustainable so that they stick. And that's the approach that we're taking. And we're leaning into healthcare transformation. So, this budget process is not over for us. We absolutely have to continue to have more conversations about what healthcare transformation means to the state of Vermont, how that's going to impact us here in Franklin and Grand Isle County. We need to finalize the impacts of House Bill 266. We need to look at a way to continue to invest in our most precious resource. We are an organization of people taking care of people. 53% of everything we spend money on is salary and benefits, and our people are our greatest asset, and we have to be able to provide market appropriate wages and benefits for our team. And of course, we will continue to work with the state and our partners, both in our local community and our adjacent hospitals, on what healthcare transformation is and means and how it will roll out in Vermont. And we will continue to be the leader as we have in years past. Before we flip to the next slide, we've been listening to the other budget hearings. We know you're very interested in executive compensation, and so rather wait for you to ask us those questions, I'm going to turn it over to our board chair, Barb Toof, who's going to go through executive compensation and the highlights of how that works. Barb?
Yes, thank you, Peter. Thanks to the Green Mountain Care Board for this opportunity, and also thanks to my team from NMC who, in the midst of putting all this together, still are taking fantastic care of our community. So much appreciation. I am here to talk a little bit about executive compensation at NMC. At our hospital, compensation for the president and CEO is set by the executive committee of the board. This includes base compensation and variable compensation. The executive committee works with our management consultant, Ovation Healthcare, and reviews regional market data, as well as data from Witt Kiefer, who is a recruitment firm that we've used in the past for our CEO searches. Base compensation for the other members of the hospital's executive team is set by the president and CEO with counsel from Human Resources. But variable compensation is always subject to approval by the executive committee of the board. Across the board, NMC targets compensation between the 50th and 55th percentile of the current market. NMC has not provided any variable compensation payments to the hospital's executive team since 2022. We are not going to provide any to the hospital's executive team in fiscal year 25, nor have we budgeted anything for fiscal year 26. Although we do set some goals and guidelines annually for our senior leadership team by creating a performance matrix that aligns with our strategic plan that you saw in the very first slide that we presented. The executive committee is beginning to create that matrix for fiscal year 26, and we will be sure to incorporate many of the Vermont principles of healthcare reform in that matrix to make sure that we're staying on track. And although we have not provided variable compensation to senior leaders, NMC has provided variable payments to medical staff and direct patient care and support folks in each of the past several years. And that includes, our nurses, our lab techs, our DI folks, EVS, and all those other folks that support the patient care. Thank you.
Great, thanks, Barb. Okay, staff. So this last slide is one that we love. So we were part of the initial pilot of the Vermont Talent Pipeline with the state. I believe it was UVM and either Rutland or Bennington that joined us with that. So what you're seeing on the far left is Kelly Campbell, our director of organizational development, and then a variety of our students. These are nurses and scrub techs for the OR, and that charming, smiling woman right up front in the scrubs is Michelle Buck, our chief nursing officer. And this is a program that we are very proud of being part of the initial phase. We continue to fund it through our own budget. We continue to participate at the state level, and we received a very generous gift from an organization in our community to continue to provide education funds to grow our own healthcare workforce internally within the community. We have an Earn While You Learn program, so students can really take any job and get to any job within our organization while getting paid to actually work, but also getting paid to study along their journey. It's a great program. It has produced a lot of great team members for us, and it's something that we get really excited about every year. So with that, that's the end of our presentation. We appreciate your time, and we look forward to your questions.
Thank you very much, Mr. Wright and team. And thank you very much for being here, Ms. Toof, and for providing testimony today. We really appreciate it when the chairs of the board participate. So we're thankful that you did. I'll turn it to Dr. Merman for any questions he has.
Good morning. Well, thanks for listening. Thanks for being here, and thanks for, I guess, listening to the other hearings that we've been doing. I hope you haven't had to endure all of them. They've been fairly long, but I appreciate your engagement. I also appreciate the clarity and transparency with your presentation, not just financial, but where you are working through the quality journey. And I think, as many others, and I'm sure you share this concern, is that I have significant concerns about the continued, just the continued low margins and the hospital sustainability and financial sustainability of your organization. So some questions related to that. Just a few from the presentation before I go into other prepared. The days cash on hand projection for the next 8 years, what have you assumed for your expense growth in that calculation?
Yeah, we've assumed a 3%, which is a little bit lower than, what we've experienced over the past 6 years. It's been more like 3.5%. But for those projections, we used 3 and thought that was a good goal to strive for.
Okay. We appreciate that goal. It's a challenge for a lot of organizations to be at 3% growth, especially, given your, while history can predict the future, it's also, you've been keeping growth very low. So, okay. One thing I'd sort of like to explore a little bit more is, what do you think are some of the challenges that have led to the low operating margins over time?
Yeah, I can start. Oh, and then Peter will. Okay, thanks. I think for us, one of our struggles has certainly been travelers. Since the beginning of the pandemic, we've struggled with travelers. Before the pandemic, it would be really unusual for NMC to have more than 2 or 3 travelers in the house at any period in time. And really with the start of the pandemic and ever since, we have not been able to get back to that. So for me, I think I see that as one of the biggest challenges, and it's why we're so nervous about not, providing any across the board increases for staff, because we are hoping and wondering if that's going to make our traveler problems even worse. So that's one of the things, but there are others, and I'll let Peter kind of give his thoughts too.
Yeah, I think, it's a long period of time, right? It goes all the way back to 2017. And so every year there are different types of challenges. I think over that time, we've become a much more lean and efficient organization. I think we've endured a lot of change. And as we kind of, as Dr. Minadeo pointed out, as we embrace evidence-based practice and the best clinical practice and have one NMC way, we're lowering our costs continuously. We work with our GPO to really keep our cost of supply incredibly low. It's around 13%. And we're continuing, one of the things we do with our collaborative is continue to drive that down. That's going to be a leading position, not just in Vermont, but across the country for an organization our size. So there have been different types of things, how we staff, the amount of travelers in any given year, the amount of locums, the last, not this year, but year before and the year before that, locum costs were really high. We've been very successful in recruitment and our growth in certain areas to open up access. We've been able to bring that down. So, the rigor and discipline of the new healthcare world is helping us. And as you see, what I'm really encouraged by is when I got here in 23, that near -7%, we've had really strong upticks. And if it weren't for travelers and the need for locums right now, I think we'd be in a better position. I worry about the escalating cost of labor across the organization. Nothing necessarily to do with, well, let me change what I said. As I said earlier, some of it has to do with our market, but some of it's just been the cost of labor in any business over the last couple of years. So I think we're doing the right things about streamlining. I think we're doing the right things about working with our collaborative partners to figure out how we continue to become more efficient. I believe that we'll get there. There is no doubt that, and I'll kind of preempt what I hope is another question about, where do we go is, I think if I were you, I would, and I've said this to some folks publicly before, I'd want to figure out how we get more patients to come to Northwestern Medical Center. I think we need to look at the out-migration from Franklin and Grand Isle County, and of the stuff that we do, there's a lot of stuff that we don't do, and obviously we can't cover that, but of the stuff we do, we need to figure out how to capture that, because that you know, our infrastructure is pretty solid, and we just need the volume to kind of come up a little bit to cover that basic infrastructure that we have.
Okay, so I just want to, so it sounds, a lot of what you said are things that should drive positive margins, lean and efficient, low cost recruitment successes, things that are that are opposing those positive margins. Travelers and outmigration are the two big, I think, that came out of that. Is that fair to say?
Yeah, I would say travelers, locum, our own labor costs, right? I mean, we're looking at the number, we constantly look at the number of people, but also the rate that we pay, for sure. And you know, out market share, out migration. I mean, we take, that's the answer to your question. Sorry.
Okay. By multiple metrics that we've seen as the board, RAND, the Burns analysis from last year, we see other pricing metrics. Northwest has really low prices, bottom decile in the country for inpatient and RAND. How do you manage low prices with all these other competing interests?
Yeah, it's really hard. I mean, you know, as you know, you folks control a lot of our pricing. So, you know, we take the cards that are dealt with us and do the best with it. I think, you know, pricing is a part of it. I wouldn't, if you know, the way this business is managed, I'm trying to say this in the right way, but the way this business is managed is we're doing everything we can to control our costs. That slide showed that. You know, the other part of it is to grow our way out of the infrastructure problem. You can either grow by rate, which I think we need to do a little bit of. I don't think we need to, you know, increase our rates by lying huge amounts, but we do need to increase our rates. And I would say, you know, last year with the rate cap for everybody, you know, if you were to give every hospital the same rate increase, a 3% rate increase for us yields very differently than it does a hospital that already has prices that are bigger than ours. And so we're kind of disproportionately negatively impacted by that. So I think that's part of it. But the other part of it too is just who from our community is leaving, and how do we figure out a way to stop that? It's what we did with Blue Cross and Blue Shield, is say, hey, if we have the lowest prices, what can we create for incentives? How can you work with your plan design and your members and those self-funded plans to do what we do for our own employees, right? Our own employees, we tier our plan to say the most affordable care that you're going to get with our plan is through us. If you choose to go somewhere else, that's fine, but it's going to cost you more money. And so we control our own kind of domestic market share that way. And I think if we can continue to rise above and capture more market share through providing faster access, providing, you know, a small local feel, that will help capture that market. And so the volume, the revenue side of that is the volume that we need to catch, and hopefully at some point looking at that rate.
Thanks. What margin would you need to avoid a bond covenant violation?
We would need about a -2% instead of a -6%.
Thanks. Have you had any indication that your 340B status is at risk due to SSI determinations or other factors related to the 340B calculation?
No. No, I believe our sole, well, I'll get over my head a little bit on this, but I believe our sole community hospital status, that specific Medicare designation that we have, helps with some of those DSH calculations that you have to meet in order to be eligible to participate in 340B. So we don't anticipate a problem or not qualifying for the program next year. We have not built anything like that into the budget.
Okay, thank you. And then what are your goals for the OB recruiting? Are you trying to, where do you stand with OB recruiting and your future approach to OB?
Thank you. It's a great question. So this has been an issue for us somewhere between 5 and 8 years, depending upon how you want to define the challenge. We have quite literally called the recruiters in this year and said, okay, of all the parameters of what we are and all the parameters we put out, what are the things that you would tell us to change to open up the doors to, more recruiter, more candidates? So they gave us a whole list of things, looking at the model, looking at compensation. We feel really strongly that we offer a base salary at the 50th percentile, which is a good place to start. But then after the first 2 years, that changes a little bit. And we expect certain levels of productivity or wages change. That's something where we might need to kind of isolate OB. We're looking at the model of kind of a more traditional model where we have 4 providers and they come in and they see patients in the clinic and they deliver babies and they do surgery and they're on call and they do all of that, to one provider in the clinic, a laborist model. So we've been looking at all of that. Some things where we have not been willing to change are, they've come back and said, hey, do you have to have board certified physicians? Yeah, absolutely. That's a non-starter for us, right? We've had a nurse midwifery program kind of on and off over the years. So we have a special OB task force of the board that combines leadership, medical staff, and board members looking at what's the history been, what are our recruitment, what are the challenges been, what are the different things we've tried, how can we do it differently? So we really are pouring a lot of energy into that. And I don't have a definitive answer for you today, but I can tell you that we're looking at everything and trying everything, and it is something that is not new, that we've been struggling with for 5, probably 8 years.
Thanks. I have a few more questions, but I think I could just send them to you in a written form and not take time today, so thank you.
Thank you, sir.
Thank you. Member Teachout?
Great, thank you. I just wanted to expand on a couple of the questions that Dr. Merman asked you. You said in order to not violate your bond covenants, you needed your operating margin to be at -2%. What commercial rate increase would get you there? I'm sure you've looked at every option.
Yes, I can do that math without too much trouble if you give me a minute.
I think one of the things that we're talking about, and while Stephanie's calculating that, is as the budget stands today, there are a lot of kind of factors. And so as we recalculate and as we kind of reach out to you and look at what we would propose for an amended budget, we want to take into all those variables. So the rate that Stephanie will give you will be as it stands today, but understand we might propose something different in the future, depending upon what comes up, what comes down, how that all moves.
It would be
Right,
approximate. Oh, sorry.
Go ahead.
It would be approximately an additional 6%.
Okay. And I understand there's a lot of moving parts in your budget. What is your timeline for kind of revising it and officially coming back? I think you said January, which seems awfully late, but I'm just curious about your process, your timeline, and how you hope to get where you need to be.
Sure, it's a very fair question. Part of our process is how do we work with the Agency of Human Services? What does regionalization, what impact does that have? We didn't want to make any guesses. I don't like a budget that's based on guesses, right? If we're going to do something, I want to know, here's our plan, here's how we go about it. We had to submit the budget we did to meet the requirement of the law. So we're going through a process of working with the Agency of Human Services to figure out what healthcare transformation and regionalization means. We also feel it's really important that we work with our board of directors. They are the boss, right? They kind of determine what's important to our community, and they keep us in check. They make sure that we're continuing to keep our community needs assessment, and they're the people boots on the ground spread all throughout our community who hear and understand the detail that we need. So they're our partner in that. We of course want to work with our medical staff and our team, but all of those people get paid, and so we can accelerate that. So we're working with the state and working with the board. If we can do that faster, we absolutely will, but we've created an internal deadline to ourselves that will be, no matter what, absolutely no later than, to be honest with you, it won't be January. It'll certainly be done before the holiday season because we all want to go home and have a nice holiday. Did that answer your question?
Yes. Yeah. Thank
Okay,
you.
good.
And I realize like the transformation work is not, a lot of it's not short-term work. So it'll be interesting to see what gets proposed. I'm remiss in not finding it, but you did mention access and wait times. And I wanted to know I wanted to know what your wait times are, if there's problem areas or areas where you have a real advantage for people to get into your facility.
Sure. Let me preface that by saying a couple of things. Wait times change every day. It's something we monitor on our referrals on our key performance indicator board, and they have, I think it's Stephanie, 3 business days to get a referral processed.
Yeah,
So
that is our internal goal.
Right. So we monitor that for every one of our clinics, and there are days where ENT, who is probably one of our most prolific, even though it's a 2-provider practice, it's one of our most prolific practices and the hardest to get into. So sometimes they meet that 3-day standards, and then somebody who does those referrals is out sick, and that'll creep up to 8 days. That's answering the referral. How long it takes to get them in, it can vary from 2 weeks to 2 months. We really get itchy and nervous when it's outside 2 months, and we're absolutely there with things like, in orthopedics, if you need your hip replaced, that's a lot further out. But we triage that based on those what's elective and what's really critical. So I give a lot of credit to our staff and our medical staff. When something is clinically imperative, they kind of work people around and like, okay, we'll stay late, we'll get them outside of the system. So the number, which varies depending upon clinic and service and day, may change. We always look at that, what's clinically relevant, and we make sure that nobody gets into I shouldn't say I make sure, we do our very best to make sure that nobody gets into a position where there would be a negative health outcome. And if we feel that we can't meet a certain standard, we will refer to any one of our peer hospitals, which is a key component. So we look at, we're adjacent to North Country Hospital. So if you're up in the eastern section of our community, they're somewhat equidistant to North Country. So sometimes we'll send folks to them. They regularly send folks to us. Obviously, we're just down the street from UVMMC, and we work very closely with them. And a little bit with Copley. You might look at a map and say, do you work closely with Copley? But there's a big old mountain and only one road to get there, and it's not necessarily conducive to things for a large part of our community. Not a lot. We don't lose a lot, or we don't send a lot to New York just because of the way insurance works.
Okay, great. And then my last kind of questions are around the ASP cap and what you're seeing there. I appreciated the revision of your estimates. I heard your testimony in the legislature, and it sounds like that'll be part of your proposal because there is a provision in the bill that allows some mitigation of the impact. So just thinking more about, I guess if you could talk a little bit more about how that affects patients in addition to the revenue impacts.
Certainly. As I testified, our prices were right around the national average. We were right around somewhere between $3 and $3.50, depending upon the drug. So we weren't in a kind of catastrophic place to begin with. I understand the imperative of the legislature. And so, for us, as I testified, the legislation puts us underwater on a lot of the key medications that we provide. And please understand, we do not infuse chemotherapy here. We haven't ever in our history, as far as I'm aware. So that's carved out. But you know, Remicade and some of those other medications, we can't acquire the drugs at 120% of ASP. So for us, it puts us underwater in the infusion center, not only from a financial standpoint, but well, from a financial standpoint. And so it really puts that program at risk. We understand the other language in the bill that allows for that mitigation. We've committed to working that part of the process. And so we're committed to keeping the infusion center open with the hope and the goal of finding that way to find balance in the ecosystem. You know, hospital pricing is nothing short of nutty. We basically do 5 things that make money, and that funds everything that doesn't. And so how we work in that ecosystem to find that equilibrium is something that we haven't defined yet, but we have faith that we can work with the staff to figure that balance.
Thank you. I think those were the areas I really wanted to explore more. And you talked about it. Dr. Merman asked some of the other questions I was interested in. So I will pass it to the next person.
Thank you.
Thank you, Member Walsh.
Yes, good morning, and thank you for the presentation. As Member Teachout was just saying, Dr. Merman, and she had asked a number of questions. I found myself, when I was preparing for this, thinking about organizations like yours, where there's alignment with statute and guidance, but it's alignment without sustainability. And we have a small handful of hospitals in that situation. And I'm wondering, Dr. Merman got to this, you had some points talking with him about travelers' expenses, outmigration, labor costs, and the way that standard guidance to all hospitals is almost regressive. It doesn't really allow you to grow in the way that you might need to for sustainability. But the question, the only question that I wanted to ask was what you'd want to tell us about helping a smaller hospital develop a safe and reliable, mission-focused culture and an affordable and sustainable financial position.
Thank you.
I see that as like your new relationship with Blue Cross Blue Shield. What can we learn from you?
Thank you, Member Walsh. I think it's really important to start that with the rules came out. Here was it's called budget guidance, but we understand that this is where you wanted us to be, and we felt the imperative. The first thing we started our budget process with is like, okay, these are the goals that we need to hit. This is what the Green Mountain Care Board is telling us. This is what they expect from us. So we start from that position, and then we work into it. And we felt it was important to do everything that we could to submit a budget that represented that. And we are where we are, and we would welcome ongoing conversations. I think, I've said that I've used the term, kind of standard increases or standard way as a bit of a blunt instrument. That's not a criticism. That's just, you have 14 hospitals in this state. They all take care of communities that are alike and also very different. They all have a long, different history of how they've approached pricing and community need. And so they're all different. And I really appreciate your question about how do you work with us and the unique area that we're in. We have things that we do really, really well, and that I think we can be a role model, and there's areas for us to grow, right? And so we're leaning into those growth areas and want to be leaders in the areas that we do really well. I think that, looking at our situation, I think, where is healthcare transformation and regionalization going to take us? Where are our strengths? What are things that we should continue to do? Here's an example. When I first came here, I absolutely love the fact that we don't quote unquote own primary care. I think it's great. I think our FQHCs and our private practices, and I think it's great because then they're focused on one thing. Rather than us managing primary care along with the 30 or 40 other departments we have, there's a leadership team that manages primary care in a program that leverages more federal dollars to help make the impact on commercial rates lower. I think it's a great program, a huge proponent of FQHCs. We have private practice that is connected with private practice and primary care across the state. That's proven to be excellent. They provide great care. They're very efficient. They do a great job. And rather than own and control, it forces us into having a collaborative and strategic partnership with those folks to move forward, right? We don't just get to say as the hospital, we're going to do this. It's always sitting at the table, and there's a balance of power in our community between home health, mental health, long-term care, primary care, and specialty and hospital services, where everybody gets an equal voice. And we work very well together. I think that's something that we could learn. What we've done with Blue Cross, hey, we're a low-cost provider. We can help you lower cost, not only to your customers through some plan redesign. So that helps everybody, right? I mean, we're working with them to say, how do we get to a win-win-win? What's a win for the patient, a win for the company that they work for, a win for Blue Cross, and a win for us. And so those are the areas that we continue to look at, and their programs and things they do in other regions work well. I think we can work on what our rates are and what's reasonable so that we don't let the pendulum swing too far. We don't want to lose our position as one of the lowest cost or a great low cost hospital. But we probably need more than, say, every other hospital in terms of a rate increase to be sustainable. So I think there are a variety of different conversations that we could have with you to make not big sweeping, but small strategic, dare I say, surgical changes to our operation and how we work with you and how you regulate us, so that we continue to be a leader in low cost increase. So we continue to be a leader in low cost, and we can continue down our high reliability journey, and at the end do what everybody wants, which is make that value equation get bigger and bigger and bigger. I hope I answered your question.
You did, and I join you in welcoming ongoing conversations, and let's see what we can do to make those happen. I'm very worried about this alignment without sustainability. If we are part of the part of Vermont that helps design the parameters of a system for healthcare delivery, then designing a system where providers who are doing all of the right things, who are aligned with state goals, who are following statute and guidance, how do we make a system where they succeed? And so I appreciate your response.
You're welcome. And my pledge to you is, as we meet that deadline, you've all talked about our new budget. Before we submit that budget, we plan on engaging your staff to say, if we move levers like this, if we do this and we do that, so here's what we're getting from the state and regionalization and healthcare transformation. Here's what we're getting from our board and what we need to do for our community. So as we move those layers, what do you think about? What are you thinking about when we do this? So that final budget resubmission to you is not a surprise or not something that we would hope you'd be like, well, this is way off. We can't accept any of this. That it's kind of working with you along the way so that by the time we get there, it makes sense to everybody involved.
I hope we make that happen. Thank you for your time.
You're welcome.
Thank you. Just a couple of quick questions. Can you describe what efforts you have in place to compete and take patients from the UVM Medical Center?
Yes, sir, I will. But I want to just say I'm very careful about compete. I think when hospitals compete, it leads to advertising and spending money, and that's wasteful, and that's not what I want to do. What we try to do when we work with our local companies is we work with Blue Cross and say, hey, look, every time someone leaves for, I'll make it up, an MRI, right? no matter where they go, whether it's UVM or New York or over to North Country, we know that those services are more expensive. Now, we know that if you stand by exit 19 at 7 a.m. in the morning and 5 or 6 at night, you see this influx. We know that we lose folks down to UVM because that's a work migration, and it is easier to get your care closer to work. So what we're trying to do is, in our value proposition, is say the quality of the care is the same, right? Our cost is lower, and how do we get you in faster? So how do we make it cheaper and faster? So that it's more convenient, so that that's the natural choice. UVM is a partner of ours. We have a lot of their, we have a cardiologist here from them. We have a little bit of pathology. We have some other areas. So we need to be careful. They provide very high-end care, and we need to be careful to work with them on that handoff. But the things that we do, that they're doing, and patients go there, we do everything we can to kind of create that value. And saying it's easier, right? You don't have to go, I've been there, you don't have to go into the garage and navigate all around. We can get you in faster, and it'll cost you less. That's what we're working with Blue Cross, and that's what we're working with insurance, employers who are self-insured. And we're doing that in a very careful way to not say we're better than them or don't go to them, come to us. Like, we want it to be their choice, and we want to maintain our partnership with UVM. So we're very careful about that.
I don't know that I agree that marketing necessarily is a net negative spend. I think certainly there are many situations where it is, but a small amount of targeted marketing to take patients from a very expensive, delayed center with the same quality as yours could actually yield significant savings for the state of Vermont. So I
agree with you. I didn't mean to characterize it differently. I just didn't want to create a marketing war between us.
Yeah, but I mean, I think there are certain advantages to the system of your hospital competing with UVM, and I think that we want you to have a positive margin, frankly. But I don't think the solution to that is necessarily just on rates. I think that certainly, to Member Merman's point, as compared to other Vermont hospitals, you do have an affordability advantage, and there is opportunity for consideration of rate with your hospital. I think in the past, we have given your hospital greater increases. I know on a smaller base than many others, but I'm more and more comfortable with doing that if you're actively competing for patients in Burlington. And if you're not, I'm less comfortable doing so.
Yeah, I have no problem. And let me say, I have no problem doing that. I'm sure my marketing staff is in the background now just jumping and going, yes, we're going to get more money because they love what they do. And I want to give credit where credit is due. I regularly have conversations with Dr. Leffler and Dr. Epen about how we do that in a meaningful way. So I don't think it's something that they're afraid of either. And so I think if we, part of our plans moving forward were how do we thoughtfully work with Blue Cross, work with UVM, to do that in a way that makes sense, that's best for the patient and best for just reducing healthcare spending. And so I agree with you, Chair Foster, on that, and that's something that we will be more aggressive about.
Yeah, and on the marketing war, the care board controls budgets, and one of the things we look at is unnecessary expenditures that don't improve health outcomes or consistent with our mission. If UVM were to engage in a expensive marketing war with you, that is an expenditure that we would look at, and I think there's a fair chance we would say no.
Right.
If they're not.
I didn't mean to insert that they would. I just always, over the course of my career, I've watched that happen in different markets, and it always frustrates me that you're spending money and just kind of, pulling resources. It's like, where should people get care? Close to home, right? I always tell folks, UVM is three things, right? There are one of the two level 1 trauma centers that take care of Vermont. They are an academic center. We don't do either of them. And so we rely heavily on them for that. They're also a community hospital for Chittenden County. And I think if you go back, at least in the 24 years that I've been in and watching healthcare in Vermont, slowly over time, with previous administrations, they have advocated for smaller hospitals not to do work, right? I mean, Dr. Bumstead used to say, you know, those little critical access hospitals should be primary care and emergency departments, and procedures and stuff should come to the medical center. I think it's very important to say current administration, I don't believe, does that. But over the course of time, if you look at market share migration in Addison County, Washington County, Lamoille County, Franklin, and Grand Isle, you'll see that more and more community hospital work has migrated there. And I think if we encourage and look at UVM as a treasured resource for that level 1 trauma center care that we desperately rely on them for, and the academic center where they're teaching our future, we get a ton of recruits from them. You know, and then let them figure out a way that they get to be the community hospital for Chittenden County, but maybe not for other small communities, and encourage, whether through plan design or other ways, for those folks to get back to their home community. I feel very strongly that UVM would welcome that. They've said that to me before, and those are the things that we try to do when we work with them. And so I think creating an education campaign with UVM, with Blue Cross, with our marketing team, would serve everybody, and that would be a win-win-win.
I agree with much of what you said as to the importance and critical role UVM plays. Very, very true. And then there's also, you know, a big backlog of patients waiting for particular services that your hospital can do, and can do quite well and quite affordably. That's not good for our healthcare system, having a backlog of patients going to an expensive place when there's others that have opportunity to increase utilization. I think that's where you can fill a void. So when you come back, it sounds like you're anticipating coming back. I think a component of that should be not just rate, but how are you going to increase utilization and offload patients that are backed up in other hospitals that are maybe more expensive. We're really looking at it from that lens, and that would be a much stronger submission to the board than simply rate. So
Message heard, and I completely agree that us getting bigger will lower the cost of healthcare in Vermont.
great. I have no other questions. Thank you very much for your presentation and your hard work on your budget.
Thank you, Chair Foster.
Thank you.
I just have a quick follow-up question, if that's okay, Owen, Chair Foster.
Please. Yeah, of course. Yeah.
I just wanted to ask, just in the lines of along the marketing and the out-migration, I'm just curious, do you have a sense of how much your community currently understands the large price differential between NMC and nearby providers? How much of information about price transparency is out there? How much do people really understand?
Here's what I'll tell you, and I'm going to say this in my opinion, because, you know, I've not done an actual formal study around it. In my opinion, it's directly related to their plan design. You know, I think someone who has a high deductible plan, they're completely dialed into the price difference. And, you know, if you have a high deductible plan and you're looking at a $3,500 fee for service, or a $1,200 or $1,600 fee for a service, you know where it is. And, you know, there's decision making that happens all the time. We have a team that regularly provides prices, and we get that. There are certain plan designs, and, you know, I think you know who they are, where their out of pocket doesn't change that much. And so they're not really worried about it. So they're worried about convenience. They're worried about what's easier for them, and not worried about price. And one of the things that I have said publicly, and I will continue to say publicly, hospitals need to change. We need to transform. I think there are several policies in the state that we need to look at, and we're going to be forced to look at. But plan design is absolutely one of the things that we need, and education and skin in the game from a patient is something that we have to figure out. And I know that's infinitely more complicated to do than it is for me to say, but I think that Vermont is at a point where we don't have the luxury of taking our time, and that needs to continue to move to the forefront.
Okay. My second question is just I appreciated the request for the hold harmless for the 1.1 million for OBGYN. And I'm just wondering if in follow-up you could just share a bit more about where that $1.1 million is coming from, perhaps maybe a year over year breakdown of the service line costs for OBGYN and where that's coming from. Just a little bit of clarity there would be really helpful.
Sure, I'll pass it to Stephanie for the detail, but the outright is losing a full-time provider who actually, to be candid with you, probably works at a productivity level. He works at the 95th productivity level, which is unhealthy and unsustainable, and honestly part of the reason that he's moving on. But you know, that comes from replacing him with locums coverage.
So that completely is one line replacement. That is what it costs to hire a locums OBGYN for 1 year.
Yes, it is
Okay.
simply, yep, it is simply the difference between employed and contracted. That's the extra 1.1 million. Yep, that's all it is.
Okay. Thank you.
But understand that's how much work that provider has done. And so we couldn't replace him with just one person, to be honest with you. And we've been recruiting for 2 others. So it's, you know, connected to the ongoing challenge that we've had.
Okay, then can I just clarify that it's not a 1-for-1? It's you're replacing one person with more than one person for the locums?
No, I'm sorry. I meant on a full-time. So that is a 1-for-1 replacement.
Okay. Okay. Thank you. That's all I had.
Sounds like we should get that guy back.
We agree.
All right, I'll turn to the healthcare advocate.
So I just have a few comments and a question. I want to push back on something you said, Mr. Wright. So I think consumers have too much skin in the game. It comes down to being overly expensive. And one of the problems with this notion of skin in the game is it's a kind of, we're taking what people learned in microeconomics 101 and we're saying it applies to healthcare. And that's just not the way healthcare works. Now, of course, you're a low-cost provider, so I'm not really speaking to you, but when you have a $9,000 deductible, that's absurd. That's way too much skin in the game to pay for an exceedingly bloated system. I do want to note, so NMC has done a wonderful job over time of coming in at guidance. If you look at their, and also is the connection between budget and actual performance. So if you look at the period from 14 to 23, excluding 20 and 21, their mean budget deviation was 1.7%. At the bottom end, so of over predicting, we have Gifford at 5.2%. And at the top end, we have RRMC under predicting by 4.9%. It looks even better when you look at median budget to actual deviation. NMC is at 0.8. At the bottom end, again, we have Gifford at 5.5%. And at the top, we have UVM at 4.1%, meaning they under-predicted NPR by a total of 4.1% on median. I think I want to reflect on something you said, Mr. Wright, that NPR is fundamentally unfair or disadvantages lower cost providers. And I'll put an even finer point on it, probably because I can. NPR is an absurdly ineffective regulatory tool. We have said this year after year after year. It does not control prices. At best, it's a control of utilization, and prices have run rampant. We are seeing the effects of this on our insurer and on consumers today. We have been seeing it for years. We are now at an inflection point. So I want to turn to my question, and it's that, so you're presenting on one hand saying you're presenting a FY26 budget, and on the other hand, you're saying essentially it's just Q1 of FY26. So which is it? Is this an FY26 budget, or is this just 1 quarter of 26 budget and you're going to be amending it?
Okay, thank you, sir. Let me answer those questions in the order in which you asked them. First, I actually don't believe we have a difference of opinion. What I said is price awareness. The question from Member Holmes was how much price awareness is there? And my comment was, I think someone with a high deductible plan has incredible price awareness because of exactly what you said. I agree, $9,000 out of pocket. is incredibly expensive. I've been on a high deductible plan before, and I sometimes wonder, like, oh, what am I going to do for this? And I think we can agree I'm probably someone who doesn't need to worry about healthcare cost. So I worry about that all the time. My comment was just that person, in my experience, has incredible price awareness, where other people who have plan designs where there's very little out of their pocket, right? There isn't an incentive for them to go to primary care versus urgent care or the emergency department. They have very little price awareness because they're not paying it. So that was my comment. And I didn't want you to think that I was taking a position. I actually think we're in perfect alignment in our opinions about that. Number two, in budget accuracy, thank you for that compliment. I want to look to Stephanie, and I think we have an incredible financial services team. We insist on great vigor. We go over the numbers and over the numbers, and we go over them every month. And I work with them closely to make sure that our forecasting is strong. I always say, hey, look, if we expect to get 100 of something, right? Please don't do 101. Let's do 99. Let's be a little bit conservative. I'd rather be 1 unit over than 1 unit under, but our real goal is to, where do we think? We look at the trends, we monitor that all the time. We do a rolling kind of assessment of where volume is. And so thank you for that recognition. It really is everything to do with Stephanie and the team that she works with about making sure that we have that pinpoint accuracy as best we can. Regarding net patient revenue, I agree. We really should be looking at prices and expense growth. As I said before, I think you want my revenue to kind of grow more than the budget because you want me to grow because my prices are lower. And your comment about our budget, is it a budget or is it a first quarter budget? I'd say yes, right? I'm telling you that I want it to be my first quarter budget at a maximum, so that I can take more time to put something together more thoughtful that is sustainable and embraces everything that's going on, so that it's real. I don't want to guess at anything. I want to understand what's going on. I want to understand what changes we're going to make and then budget for that. But I also realize the Green Mountain Care Board doesn't have to accept that. I could submit it and they could say no. And like, okay, so that might have to be where we are. I hope that's not the case. So again, it's really both. But if you're asking me what my hope, my goal, and my request is yeah, at most it's my first quarter budget.
Okay. And so I guess this is more of a, well, these are just two cautions or follow-ups. Is one, you probably, if you haven't already, take another look at the standards for amending a budget. And unfortunately, in this case, your forthrightness is coming around to bite you, because the standard is whether something is unknown or unexpected. And of course, it's a difficult position for you right now to say, hey, these were unknown or unexpected conditions, because saying, oh, we need more time for our board to work this out for 3 to 6 months, that's known. I will say this other thing, and this is just one slight caution, is that, we'll know how this plays out, I guess, come November, but I think unfortunately the enhanced subsidies will probably lapse, which will mean you'll have more uninsured most likely, and you are going to have a greater challenge ahead of you for calendar year 2026 to deal with free care and bad debt. I think that's the unfortunate reality, and I think we can expect that. 90% chance that actually happens.
Yeah, yes, sir. I would say, again, I find myself in agreement. Look, I'm just honest. Like, I don't know. I'm not really a politician. I don't really know how to, do the dance all that well, as my staff will confer. I just feel the way I was taught and grew up in this business is just do the right thing. And the right thing is always being honest. So here we are being open and honest with you. You're right. We knew the big, beautiful bill was coming. We knew healthcare transformation was coming, but we also don't know what impact they're having on my organization. And so what I would say is, if to thread the needle on the rules, if you will, is I can't tell you today what both of those, what impact they're
Yeah.
going to have. And so if you want a budget that is our honest to goodness best reflection of what we think is going to happen and what we can control, that's the timeline. And we certainly, it takes a long time to develop the budget. It takes a month just for us to put it in the system. And so when you think about the end of May, when we had to kind of stamp it, what we knew then versus what we know now, I'm comfortable in presenting to the community and to our regulators in an honest way that that's the situation. And I will have faith that they will do what's best for us and for Vermont and the people that we serve.
Fair enough. Thank you so much. That's all my questions.
You're welcome. I
Thanks,
appreciate your questions and the rigor.
Thank you. Any public comment at this time? Okay, hearing none. Thank you all very, very much for your thoughtful presentation and for your budget submission. I enjoyed the dialogue. I'm sure all the board members appreciated the information and the candid information you gave us. Really important part of this process. So I will take a recess and we will come back. Get the time. We will come back at 2:45 for the Gifford Medical Center budget presentation. And we'll recess till then. Thank you all very much.